Hello, everyone, and welcome to Toronto and to our yearly massage therapy convention. We are Kayli Liz and Elizabeth Wilson, and we will be going over trigger point in anterior scalene, signs and symptoms, how to treat, and some common errors done by massage therapists. First off, I just want to remind everyone what a trigger point is. A trigger point is a sensitive or tender area in the body that may cause pain and discomfort. The muscle may cause generalized musculoskeletal pain when overstimulated. The effect of the trigger point may also be felt elsewhere in the body. To identify the anterior scalene or trigger point in anterior scalene, we would make the client contract that muscle and see if there is any pain. To contract the anterior scalene, we would flex the neck and laterally flex the neck to the same side. Next, we would like to talk about signs and symptoms of trigger points. The CMTO recognizes 3 ways in which we can identify trigger points in the body. They are local tenderness within a top band, local twitch response, and or the client's report of referred pain. Referred pain pattern in anterior scalene is pain in the upper arm or upper chest. The client may also complain of tenderness or autonomic phenomenon, such as goosebumps or runny nose. The CMTO only needs 2 of the 3 signs as an indication of a trigger point. Specifically, when talking about the anterior scalene, there are reported symptoms such as new or worsening headaches, a positive scalene cramp test, which we would get the client to rotate their neck to one side so that they are tucking their chin behind the clavicle. The positive indication of this scalene cramp test would be that the scalene being contracted would get a cramp in the muscle. Also, a positive upper limb tension test number 1, which can be done for thoracic outlet syndrome, could indicate some increased tension or trigger point within the anterior scalene. Pain in the anterior upper limb and chest, much like the symptoms of a heart attack, may also be a sign or symptom of a trigger point in the scalene. Also, the client may report of hoarseness of voice, which may be caused because of the distal attachment onto the first rib. Now we're going to talk about how to treat a trigger point. There are several ways in which to treat a trigger point, such as petrissage, which can be used to warm up the tissue. This may include wringing, muscle squeezing, or effleurage specific kneading. Next, to treat the trigger point, we could start by stripping the muscle from its origin and insertion, which specifically for the anterior scalene is the transverse processes of C6 and the first rib. You will want to perform this technique with even pressure and depth along the muscle belly. Stripping the muscle may help to relieve the pain and get rid of the trigger point, but if not, we can move on to specific compression. For specific compression, we will hold pressure and depth for 30 to 45 seconds. This may relieve the trigger point in one go, but if not, this can be repeated about 3 times and flushing the area in between each 30 to 45 second time frame. Both muscle stripping and specific compression must be followed by moist heat and stretch. To stretch the anterior scalene, we will want to extend the neck and contralaterally laterally flex. We can also perform connective tissue techniques such as skin rolling, myofascial release, and direct fascial technique to decrease any fascial adhesions and to help prevent any future trigger points. There are also other ways we can treat trigger points as long as they are in our scope of practice, such as passive stretch, active range of motion, PNF, high voltage galvanic stimulation, or therapeutic ultrasound. So the goals throughout our treatment should be to reduce pain by performing the techniques correctly and safely. We must also educate the client about good posture when seated or standing. Breathing effectively through the nose and out through the mouth is another way to educate the client about reducing any tension in the anterior scalene. Also educating the client the importance of stretching after any activity is a great way to benefit the client. We also want to regain or maintain their range of motion, and specifically for anterior scalene, stretching the muscle by again extending the neck and laterally flexing to the opposite side. There may also be some functional losses with the trigger point, so we will want to talk about them during our assessment about any functional losses, which may include pain when reading a book or watching TV, and driving and checking the blind spot. There are also some common errors that massage therapists or therapists alike may do when trying to treat a trigger point. One common error is pressure is applied too quickly. This may make the client want to stop the technique, which therefore you are not treating the trigger point effectively. Also, the pressure may exceed the client's pain tolerance. Again, this may get the client to terminate the technique or invoke a autonomic nervous system response, specifically sympathetic. When the pressure is not maintained on the client's trigger point, there may be no change in symptoms, which does not help to fix any pain. Insufficient depth is also the same as pressure not being maintained in the sense that there is no change in symptoms. Also, ignoring any possible signs of secondary trigger points, such as satellite trigger points, may cause new symptoms to appear. Educating the client about self-stretch and other ways to decrease the potential of another trigger point is a great way for the client to trust what you're doing is actually going to help them. So for self-stretch, we want to correct or teach any techniques the client does for self-stretch. Next, gentle active range of motion through the full range to produce an isotonic contraction of the affected muscle is also a great way to decrease the likelihood of a trigger point. Applying moist heat to the trigger point may also help to decrease tension in the muscle, therefore decreasing the likelihood of another trigger point. Talking to your client about self-massage, whether it being with their hands or another handheld massage tool, can help to decrease trigger point pain as well. Talking to your client about good posture when seated or standing is another great way for the client to reduce their symptoms and likelihood of a trigger point. We want them to stand nice and tall, shoulders back, feet about shoulder width apart, and head and eyes looking forward. When seated, we also want shoulders down and back with elbows to the side, sitting up nice and tall, and having both feet on the ground. With our research, the upper quarter myofascial pain syndrome study was a regional muscle distribution, pain intensity, and treatment outcome in upper quarter myofascial pain syndrome. Patients with the upper quadrant myofascial pain syndrome were referred to an occupational therapist of a multidisciplinary pain clinic over a 2-year period. Active trigger points were identified systematically, and pain interventions included ischemic compression techniques, passive stretching, and physical modalities. In the study, there were 32 patients, 25 of them being female and 7 being male. 94% of the patients had trigger points in the trapezius, and 63 reported pain and trigger point symptoms in scalenes. Other muscles that were affected were rhomboids and sternocleidomastoid. Upper quarter myofascial pain syndrome may result in chronic severe pain, frequently involving the traps. Physical therapeutic interventions can result in significant pain relief. In the end, the compression techniques, passive stretching, and physical modalities help to decrease active trigger point pain in these patients. Another research article that we found talked about myofascial trigger points, their pain, disability, and sleep quality in individuals with mechanical neck pain. The purpose of this study was to investigate the presence of active trigger points in a greater number of muscles than previous studies before them, and the relation between the presence of trigger points, the intensity of the pain, any disabilities, and the sleep quality in mechanical neck pain. 15 patients with mechanical neck pain, 87% of them being women, and 12 controls participated in this study, with a total of 27 patients. Myofascial trigger points were bilaterally explored in the upper traps, splenus capitis, semispinalis capitis, sternocleidomastoid, levator scapula, and scalene muscles. The pain was collected with a numerical pain rate 0 to 10. Disability was assessed with Neck Disability Index, and sleep quality was assessed with the Pittsburgh Sleep Quality Index. Patients exhibited higher disability and worse sleep than the control group. Sleep quality was associated with pain intensity and disability. There were no association between active trigger points and the intensity of pain, disability, or sleep quality. Thank you so much for coming out and listening to our presentation of trigger points in anterior scalenes, and I hope you have a wonderful rest of your day. Thanks again.